You're listening to Medscape's In Discussion series on chronic obstructive pulmonary disease, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Leah Witt. Dr. Witt is a geriatrician and pulmonologist at the University of California, San Francisco. At UCSF, she is also the Pulmonary Associate Chief for Ambulatory Affairs, a coach for the Pulmonary and Critical Care Medicine Fellowship, and a passionate advocate for improving the care of older adults with chronic lung disease. Dr. Witt is an associate editor, producer, and sometimes co-host with The Curbsiders, a popular internal medicine podcast where she's covered topics on chronic lung disease, geriatrics, and gender equity. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Leah Witt. Welcome back to Season 1 of the Medscape in Discussion COPD podcast series. Today we're talking about a geriatrics-focused approach to COPD management. First, let me introduce my guest, Adrian Austin, MD, MS, CR. Adrian is an intensivist, pulmonologist, and geriatrician. Like me, he's both a pulmonologist and a geriatrician, so this topic is near and dear to my heart. His clinical interests are preserving older adults' functionality by focusing on disorders of the respiratory system and managing issues faced by survivors of severe critical illness. Over the past 6 years, he's cared for older adults with respiratory diseases in his geriatric pulmonary clinic at UNC. His research focuses on reducing the incidence and impact of delirium. Primarily, he is interested in using pharmacogenetics-driven medication selection to reduce delirium in the ICU setting. He also has an interest and expertise in using telemedicine for delirium assessment. Welcome to the Medscape in Discussion podcast, Adrian.
Thank you, Leah. It's great to be here.
All right, so we like to start these episodes by getting to know you outside of medicine because we know you're an expert pulmonologist and geriatrician, but what are you doing or thinking about outside of medicine?
I love to read science-heavy books or listen to them on tape, and recently I've been reading and listening to, depending on time of day, to a book called Other Minds. It's about development of consciousness evolutionarily in humans, but primarily in other animals such as like octopus. It's really an interesting take, and it's sort of philosophical in its bent as well. I find it entertaining.
That's really interesting. And like most of our guests' recommendations, much more cultured than what I'm going to recommend. Well, I love podcasts, educational podcasts. I love medical podcasts. I just really need a diet of pop culture podcasts to really relax. So my recommendation is the New York Times Popcast, where they dive deep into usually pop music, but there's some rap and hip hop. We're recording this pre the Tortured Poets Department release, the new Taylor Swift album. So I am eagerly waiting for the album and the podcast discussion. Let's talk about COPD and geriatrics. Our case today is Mr. Rivera. This is the same patient that we've been talking about all season. He's 78. He has COPD. He has group E high exacerbation COPD. His FEV1 to FVC ratio is 0.65. His FEV1 is 60% predicted. But now I'm going to get to the stuff that you and I care about as geriatricians. So that's function, cognition, comorbidities. So function, he is living alone. He says he's able to do all of his activities of daily living, his ADLs, independently, like bathing, dressing. But he needs more help with the IADLs, the instrumental activities of daily living, like shopping. Mostly because he gets too short of breath, but also his daughter has noticed that he seems a bit more confused and she's having to help him with finances, bill pay, things like that because of the confusion. He also has heart disease. He has heart failure with a preserved ejection fraction. He's got diabetes. He's taking a lot of medications. This is a typical older adult that we would see in our pulmonary clinic. So I want to start by asking you, how does your geriatric approach as a geriatrician affect how you approach somebody with COPD in the older adult?
Yes. So for patients with COPD or older adults that come in with shortness of breath, which is more commonly what I see, what I want to know is how does this affect your life? And the way I start visits generically is I go in and I say, how can I help you today? Sometimes they're short of breath and it doesn't particularly bother them. Sometimes it's very debilitating. They can no longer do things that give them great value in life. And one of the core geriatric principles is aligning the care that we provide with the patient's values and desires and trying to maximize their quality of life. And so that's what I focus on. And I ask questions to really dive deep into that, including their ability to do their IADLs, their ADLs, and to do things they enjoy, gardening being an example from a patient I saw a couple of days ago.
Yeah, geriatrics approach is really amorphous and can be so hard to define. I really like the IHI, the Institute for Healthcare Improvement, and John A. Hartford Foundation's definition. They use the 4 M's. So there's meditation, medications, what matters, and mobility. So that's a great framework. And the American Geriatric Society adds a 5th M, multimorbidity. We can attack each element within the COPD framework. One of my mentors has said that a really important principle to consider when you're approaching something like shortness of breath is that Occam's razor doesn't apply in geriatrics. So Mr. Rivera has shortness of breath and COPD. That doesn't mean that's the only reason he's short of breath. So how do you think about multimorbidity when you're saying this patient with shortness of breath, he's coming to you for COPD? Are you revisiting the differential diagnosis every visit?
Certainly for new patients, for ones that I maybe haven't seen multiple times. I do have patients I've seen for years, and that makes it easier. But instead of Occam's razor, I think, we go with Hickham's dictum, which is patients can have as many diagnoses as they please. When I see somebody with shortness of breath for COPD, the question I have is this COPD? And as often as not, I'll find that it's not that's the driver of their symptom, or they may not have COPD at all. I think it's important to remember that people that come in with shortness of breath that have a history of smoking don't inherently have COPD. And I find patients being labeled as that, which is sort of a stigmatizing label attached to patients all the time that may or may not have it. So I've cured a lot of COPD, jokingly, by saying you don't in fact have that, but you have XYZ, heart failure or something else.
Right. That's why spirometry is so important. You cannot make the diagnosis without spirometry or symptoms that fit. What important comorbidities or what is key on the differential when he's coming with shortness of breath?
Heart failure or arrhythmia, cardiac issues in general. Other diseases affecting the lungs, a neuromuscular disorder. I've diagnosed ALS that's presenting as shortness of breath in my clinic. Chronic respiratory infections such as non-tuberculous mycobacterium, prior CVA, medication effect. Somebody has a high dose of beta blocker and can't increase their heart rate when they get up and move around, and consequently, they get short of breath. It's just a very broad differential.
Yeah, I think revisiting that differential every time you see a patient, especially with progressive respiratory symptoms, is in the older adult is so important, because that shared risk factor of usually smoking or air pollution can cause so many other comorbidities. So that leads us to talk about cognitive impairment, which is present in Mr. Rivera, it seems. So I'm wondering if you're seeing a lot of cognitive impairment in people with COPD.
Yes, I certainly observe that in my clinic, particularly in patients over age 80. What I observe is, I don't think surprising. It fits with the literature. Cognitive impairment and COPD are well documented to go hand in hand across a number of observational studies. I don't know if there's a causative effect. I honestly don't think that's been explored, at least not to my knowledge. Sort of the things that put you at risk for cognitive impairment also put you at risk for COPD. Vascular disease, for example, it's smoking-related disease, immobility. So they go hand in hand. And it can be subtle, but it's important because it can really impact the ability of patients to do the therapies that you're recommending.
And the brain is so sensitive. I think we talked about this. So sensitive to hypoglycemia, so sensitive to hypoxemia. Tell me what you've seen there.
The brain is sensitive to hypoxia. Some of the key reactions, for example, if you recall your biochemistry, the conversion of dopamine to norepinephrine is an O2 dependent process in the brain. So some of them are really dependent on having adequate oxygenation. Chronic hypoxia can certainly accelerate, in my opinion, cognitive impairment and also make patients feel lousy. They just don't feel like they have energy.
For resting hypoxemia, certainly when corrected with supplemental oxygen, I've had several cases in my own clinic where people start thinking better. It makes a lot of sense, but it's one of those instances where you can really improve someone's cognition with an appropriate therapy. So since cognitive impairment is so common with COPD, what do you think about the role of pulmonologists in assessing for cognitive impairment?
My bias is that we should. And in every patient, we could probably spend a lot of time discussing that. But in a subset of patients, I think we definitively should. The patients that are needing oxygen, that are on the older end, I would arbitrarily say over age 80, we should be screening because the likelihood of them having cognitive impairment is high. And there are screening tests available. I like the mini-cog, which is a brief test that takes less than 5 minutes.
I think the mini-cog is so useful, and definitely anyone can learn it, from your medical assistant to your nurse to the subspecialist. I'm just thinking, how do we sell our colleagues on becoming mini geriatricians? How do you think it affects management if we're picking up cognitive impairment in the pulmonary clinic?
If somebody is cognitively impaired, I think that they're likely to not be able to use the inhalers that we're prescribing or have difficulty with them. It is also likely, in my opinion, that they may struggle with portable oxygen. If they have some cognitive impairment, perhaps there are falls risk. You're giving them a tether, a nasal cannula that's following them around. You just need to be thoughtful about whether they really need it or not.
The inhalers, we talked in a previous episode with Amberlene Martirosov about what goes into correct use of an inhaler, and it is quite complicated, even for the person who is quite cognitively intact or medically illiterate. So certainly, if there's any suspicion of cognitive impairment, your concern for incorrect inhaler use goes way up. I'm wondering if we can talk for a second about what is the mini-cog. We've both said it's very easy, but how do you do it?
Sure. It tests for recall, registry, and a clock draw. So you give a patient a list of 3 words, ask them to repeat it back to you, ask them to remember those 3 words because you're going to ask them again in a few minutes. Then you get them to do a clock draw test, and then you ask them for the 3 words again. And an abnormal clock draw or recalling less than 2 of the 3 words is considered an abnormal screening test. It's a screening test, meaning that it's pretty sensitive at picking up cognitive impairment, but not necessarily specific.
Right. And if I see an abnormal mini-cog, I usually recommend a MOCA. Either I'm doing it or I'm asking their primary care doctor to do it. I always use the same 3 words so I don't forget them: tree, ball, and flag. Tip, you may want to set a timer for 3 minutes. I have forgotten to ask the 3 words. That was embarrassing. So don't do that. Don't be like that. And then I always give the same time. I always ask people to put the clock at 10 after 11 or 11:10. Helps if you keep things the same.
Completely agree. I do apple, table, penny, and also do 10 after 11. That's the way I was taught, and I think that's the way the test was validated. So
Yes. Okay, great. So hopefully we've convinced pulmonologists and primary care doctors that cognitive assessments really do make a difference or are important for COPD. And the prevalence is definitely higher and affects disease management. But now I want to talk about function. So that's one of the M's. Mobility encapsulates function. So what do geriatricians mean by function, ADLs and IADLs, and why does this matter?
We mean, as geriatricians, the ability to perform your day-to-day living task, if you will. Can you dress yourself? Are you too short of breath to dress yourself? That's pretty far on the extreme, but we see that. Can you cook your own meals? Can you stand up long enough in front of a range to cook? Or are you too short of breath for that? Would be an example of somebody with COPD struggling. Can you bathe yourself? Are you able to drive? Do you get out of the house? Are you so burdened by your symptoms that you're scared to leave the house? Really, what I want to know is, what would you like to be able to do with your life? And if you're unable to do those things, how much is your breathing or respiratory symptoms driving that?
Yep, absolutely. So a great definition of disability is the distance between your environment and what you're capable of. And aids, durable medical equipment, recommendations that we're making, we're trying to reduce the distance between that environment and ability mismatch. What assessments are you doing? And then what sorts of referrals, DME, what are you thinking about in your pulmonary geriatrics clinic?
Baseline assessments, I try to get a 6-minute walk on every patient that can do one that I'm seeing is new for multiple reasons. A 6-minute walk is a poor man like cardiopulmonary stress test, if you will. And I'm paying attention to multiple things. Do they need oxygen, for example? But really, the distance is helpful, and what happens with their heart rate and blood pressure is also helpful. But that distance you can use to calculate their gait speed, because if a patient ambulates more than 360 meters over 360 seconds, 6 minutes, then their gait speed is going to be greater than a meter per second, which is associated with a lot of positive outcomes. A gait speed of less than a meter per second and really less than 0.8 meters per second is associated with pick an outcome of interest: falls, mortality, multiple other things. So that's sort of my arbitrary breakpoint. Is it greater than meter second, less than a meter per second? If it's greater, then that's great. If it's less, then that's the patient I'm going to be bringing back quickly, ensuring they have family support at home, ensuring that they have been through pulmonary rehab.
Yes, pulmonary rehab is so important. I love that you're doing that calculation. I do some geriatrics consults and we have 4 meters marked out and we do 4-meter walk tests. But I do think gait speed really gives you a key. I think the lowest resource assessment is just walking your patient to or from the waiting room and watching, are they like wall surfing, furniture surfing? Do they have to use their arms to stand up? Those really informal assessments give you a key about their robustness or frailty.
Completely agree. Getting people up out of the chair to get to the exam table can give you a lot of information too.
Mm-hmm. In terms of what do, I really like being aggressive about DMV disability placards. I am not putting up any barriers if FEV1 is less than a liter or if there's some major mobility impairment. What are other things that you're thinking about? Are you recommending the shower chair or the raised toilet seat or the wheelchair? Or how are you coordinating with primary care doctors on that sort of stuff?
I honestly tend to steer clear of wheelchairs if I can avoid them, because I want our patients to ambulate. I brought it up earlier. One of my sort of core recommendations for everybody is pulmonary rehab, getting people to move. And the way I present it to patients is, and this is true, I've sent hundreds, if not thousands of patients to pulmonary rehab, and I've had 0 tell me it made them worse.
I like that.
I've had some that haven't found a substantial benefit, but I've had more than that number to say, oh, yes, I feel a lot better. And so that's a low harm, low cost intervention to start with. And then I also am big on the disability placards as well.
And this term of frailty is sort of a buzzy term in subspecialties, though I think in geriatrics, they've been talking about it forever. I'll define it in a second. But frailty has been shown to actually be improvable with pulmonary rehab, which is pretty amazing.
Talking about that gait speed, you can take people's gait speed and increase it with pulmonary rehab fairly dramatically.
Right. So there are actually, when we think about someone being frail, we think about that as being fixed and it worsens with disease severity or with age, but actually we're finding more and more that it's not fixed and there are some reversible elements of frailty. I'll just define frailty for a second. And I think it's defined variably, but it's usually thought of as a multi-system, multi-dimensional impairment in many different things. Their gait speed in social, emotional functioning. The frailty phenotype, for example, has some questions about mental health symptoms, how much activity people are doing. So it's really a comprehensive assessment of how someone is doing. It replaces what we used to call the eyeball test, like is somebody frail or not? We're trying to get a little bit more granularity to that. And it's really amazing that some of these things that we're talking about, pulmonary rehab, can improve someone's frailty. I wanted to ask you if any of this impacts you already talked about this a little bit, but impacts your thoughts about giving somebody oxygen. You mentioned maybe cognitive impairment and oxygen. You're worried that maybe they won't use it correctly or they're a fall risk, but then again, maybe it will improve their cognitive impairment. How do you think about someone who's frail and prescribing oxygen?
My approach to oxygen is if patients are hypoxic at rest, then I prescribe oxygen. I think that is a clear decision point in my mind. If the patients aren't hypoxic with exertion, then I don't. It's the patients that are in between, the patients that are hypoxic with exertion. And the ones that I'm really have equipoise about are the ones that are not severely hypoxic. I mean, if somebody's dropping their O2 saturations into the 70s and turning blue with ambulation, they probably need some oxygen just to prevent them from falling out. More often than not, it's the patients that will desaturate into the mid 80s, perhaps low 80s with ambulation. And then upon resting, will recover, typically in the low 90s. There's not evidence that giving them oxygen will affect their mortality. So I take it case by case. If the patient is otherwise not frail and the oxygen makes them feel better, then it's something that I would recommend. But it's certainly not a hard and fast because I don't want them to trip over it.
Yeah, and I don't want them to never leave their house because they can't figure out how to manage it or they can't get a portable concentrator. So a lot of considerations there. Well, I think we've had an excellent geriatric-focused COPD conversation today. I'm wondering if you have any key points that you want to leave our listeners with and any resources they should check out.
So, key points. Not all shortness of breath in older adults that have smoked is COPD. Think about cognitive impairment, pro-pulmonary rehab. If a patient qualifies for pulmonary rehab, I would recommend it. It's not going to harm them. And then for resources, there's the ATS Older Adult Toolkit that can be found on the American Thoracic Society website that you and I, amongst others, that developed. And we've also written a couple of book chapters in Reichel's Care of the Elderly on pulmonary disease in older adults, both of which I find helpful and a sort of a good general compendium of how to approach this population.
Great. Thank you so much, Adrian. Today, we've talked to Adrian Austin. What we talked about today reinforced my message and my strong view that subspecialists should equip themselves to be mini geriatricians. There just are not enough geriatric specialists to take care of everyone who needs one. So it behooves us all to become experts in taking care of older adults with chronic diseases. Thank you so much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on COPD. This is Dr. Leah Witt for the Medscape in Discussion COPD podcast.
Thanks for listening to Medscape's In Discussion Chronic Obstructive Pulmonary Disease podcast series with our host, Dr. Leah Witt. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on chronic obstructive pulmonary disease.